this area. So you got to be careful when you're dealing with individuals in this immediate area, and make sure that this particular problem isn't happening with them. Okay. And of course, like I said, nicotine and caffeine, we're going to talk about a little bit on their own. So cocaine, it can be inhaled or ingested. The effect is has a sudden burst of mental alertness and energy. The individual feels very self-confident when they ingest it, feel very much in control, feel very social. They get what's called a cocaine rush. And this typically lasts about 10 to 20 minutes. Okay. And unfortunately, it's followed, if they don't ingest more cocaine on top of that, it's followed by an intense letdown where they can become very irritable, depressed, tired. They're craving more of the drug. Now, crack cocaine gives a rapid high with intense euphoria, and the crash following it is typically a little bit more dramatic. And it is very, very extremely addictive, crack cocaine. Now, when we talk about intoxication, death generally results from respiratory failure. A lot of individuals that abuse or are addicted to cocaine also take alcohol or ingest alcohol, and these two together are very, very dangerous because each drug causes longer duration of the other to occur in the brain, and therefore being more toxic to the individual. There's a lot of deaths that occur because of the combination of alcohol and cocaine. And with this intoxication, they typically, particularly if alcohol accompanies it, can become very, very, very restless and experience tremors. Start having those convulsions. If they are withdrawing from cocaine, you're going to see severe anxiety and intense depression. And a lot of times, if they're withdrawing because they can't get their hands on more cocaine or whatever, they will be trying to get their hands on anything to substitute. They will be big-time drug seekers in a sense. So cocaine, recovery with these individuals is tough because of the very intense cravings that this drug causes. Okay. Your amphetamines, they block the reuptake of norepinephrine and dopamine. Okay. They're used all the time to treat ADHD in children, narcolepsy, sometimes depression, and sometimes obesity, right? But people abuse amphetamines for increased alertness, concentration, energy, euphoria, and appetite suppression. But we also get those physical consequences of our peripheral nervous system, of tachycardia, arrhythmias, increased blood pressure, and peripheral hypothermia. Methamphetamines, what that does is give that release of excess dopamine. Remember she talked about dopamine and the pathology of addiction and that we need it for survival? Okay. Well, here these individuals get that excess release. So it is very highly, highly addictive. And unfortunately, and I say that because of what a bad drug it is, it's very cheap and easy to make. And that's probably why it is the number one problem in this area. It has also the problematic area of possibly leading to seizures, but dependence on methamphetamines and can lead to psychosis. You usually see a lot of weight loss with these individuals, tooth decay. That can get those sores on their body. And sometimes it's from an excoriation problem that develops. MDMA or ecstasy is another drug that you will see used, street drug. Rohypnol and GHB, ketamine, those are your date rape drugs. The thing about those drugs is they're colorless, tasteless, and odorless. So that's how come an individual can ingest them and not really know that they have ingested them. But if you mix it with alcohol, it can totally incapacitate the individual, cause them to feel euphoric, give them amnesia where they can't remember what happened. Nicotine. Well, I talk about specifically, nicotine because that's what's the addictive chemical found in tobacco. But so when I say nicotine, just think about all tobacco products, okay? Because smoking, we know, you've learned how smoking is dangerous to your physical health. Arteriosclerosis is a big medical complication that can result from nicotine. Okay, not to mention the pulmonary problems that can occur. These people abuse nicotine. They have to have that cigarette. They smoke all the time because it causes increased alertness, concentration, attention, and appetite suppression. Those individuals that are trying to stop smoking, that is sometimes why failure occurs, because they start gaining weight and they don't like that. So they go back to smoking. If they're withdrawing from nicotine, they can develop headaches, difficulty sleeping, gastric distress, irritability, depression. I mean, the withdrawal is making sense, right? We're talking about stimulants. And if you're coming off that stimulant, you think high, everything's up here, you're going to see those opposite effects. One big thing about nicotine is these individuals need a lot of encouragement, that it typically takes more than one way for them to be successful. There's patches, the gum that they can use. Now there's drugs. And one of the big ones we talked about, bupropion. As an antidepressant is Wellbutrin, but as Zyban, it's been proven to help decrease smoking and help individuals be successful. but there's a whole lot of other different methods out there. And these folks, if they stop, typically they're going to pick it up again, but they need to be cheered on to, hey, that doesn't mean you can't be successful the next time. Okay? They also need to know that substituting with e-cigarettes and vapes are not a substitution. Those products are just as dangerous, pulmonary wise. Okay? Caffeine stimulates the cerebral cortex and it increases mental acuity. I don't know about you, but I'm one of those folks that typically have to have that first cup of coffee in the morning. But if we get intoxicated, think of all the products that are out there, not just coffee, although we have a coffee bar just about on every corner of our cities nowadays, and that alone is a big change. But we have all these other products like Red Bull and stuff that are full of caffeine. So if an individual gets intoxicated, they can become very restless, nervous, excited. They have a flushed face. They get diaphoretic, psychomotor agitation, get tachycardia, arrhythmias. Okay. And again, if they're getting off of it or they're crashing, well, one of the first big ones is that headache. If I skip my morning coffee, I typically have a headache a little bit later in the day. But drowsiness, fatigue, difficulty concentrating, you just get on that sleepy side. Cannabis, marijuana, or weed is the next category I want to talk about. It's known by a lot of other names, okay? Mary Jane, there's a bunch out there. You know, the THC is the active ingredient, and in your lab reports, if they're positive for marijuana, it's reported as that THC. The effects, it causes relaxation, drowsiness, euphoria, time disorientation, sometimes food cravings. Marijuana is fat soluble. It's absorbed rapidly after being smoked or taken orally. Now, if you ingest marijuana, there is no set time because it is fat soluble as to when you can safely take a drug test. Because sometimes it's still there months afterwards. So you got to be careful. Long-term use has been shown to decrease that motivational drive in individuals. Okay. It can also interfere with the ability to form memories and recall events and help us shift our attention from one thing to another. When somebody smokes marijuana or uses it, the effects begin immediately after the drug enters the brain, and the effects of the drug are typically there for about 1 to 3 hours. Okay. Now, our danger is the synthetic marijuana that is around. Just be very, very careful, folks, okay? There's a lot of research that has shown a lot of these mass murders that have happened in our country. The individuals had synthetic marijuana use, okay, in their history, their background. And it can lead to quicker psychiatric problems in general. And nothing, our public needs to be educated that nothing is safe out there. You can't trust anything that you buy off the streets. And the chances of you picking up something that is synthetic or laced, is more the rule than it is the exception. But the synthetic, the reason I want to really point that out is we really see more problems with that and the problems it creates for individuals. Hallucinogens, this is the next category. Hallucinogens can be made from plant sources or mushrooms, or it can be man-made. Hallucinogens are also known as dissociative drugs. Number one, drugs that produce euphoria or dysphoria. It can cause negative sensations or what they call bad trips sometimes. But it typically causes that euphoric effect. The person can get altered body image distortion. They can get confused, have lack of coordination, impaired judgment and memory. Okay? So because of that, the second point is I want you to remember it can cause very profound hallucinations and profound distortions in their, reality, what they're looking at. There's a whole lot of different hallucinogens out there. LSD is one of the most common ones. When you think hallucinogen, that typically comes to mind. On the dissociative side, it's the PCP that you often think about. So the third thing I want you to think about when they're in that acute stage of having ingested a hallucinogen, the possibility that they may be combative is very high. So safety is a big priority with these individuals. So what's some of the things, remember I told you it can cause euphoria, dysphoria, distortion of the reality. You can do with the environment. Think about it. Reduce noise levels. Get them in an area, that's not so traffic heavy. Look at your lighting. You don't want bright lights on, possibly. You want the environment to be low stimuli for those individuals to help them and keep them safe. These people, are the ones that have gotten up on railings and such and jumped because they didn't know they were putting themselves in danger. They thought they were invincible. But they can experience that bad trip, which can be very frightening. Okay, opioids are next. The United States is in the midst of an epidemic of prescription opioid deaths. There's been a slight decrease since this tightness has occurred on prescription drugs. But since that has occurred, we've seen an increase in heroin use or the illegal opioid. So before the crackdown, the prescription drugs were the main thing that were being used. We saw less problems with the heroin, although it was still there and such. But since we've had that crackdown on prescription drugs, we've seen a rise with the heroin. So prescription or over-the-counter opioid abuse means when you take the medication that's prescribed for someone else, you take a drug in higher quantity or in another manner than what it's prescribed for, or you take a drug for another purpose than it's prescribed. When you think of your opioids, oxycodone, hydrocodone, morphine, fentanyl, codeine, those are just to name the most common and popular ones, probably. Over the counter, you got to be careful. There's cough medicines that contain dextromethorphan, okay? And they can have similar effects when cooked down and such, like with your ketamine or PCP that I talked about. And of course, the legal opioid that you need to take attention to is your heroin. So opioid is any agonist that's any substance that acts as a agonist. Okay, it doesn't have to be direct agonist, but any substance that acts as an agonist, and it binds to the opioid receptor in the body. So what do opioids cause? Y'all should all know this already. CNS depression. So it's a central nervous system depressant too, like your alcohol and your benzos, but it doesn't act the same way as your alcohol and benzos, okay? What else? What do you tell your patients if you give them pain medicine? Be careful, yeah. Getting out of bed, call for assistance, getting up. Make sure you increase your fluids, dietary intake of fiber, because it can lead to constipation. So physical dependence can develop rapidly from the misuse of opioid, okay? Heroin, again, is a highly addictive drug. It's the most abused opioid now, most rapid acting of the opioids. It produces a profound degree of tolerance and physical dependence. And because of that are powerful motivating factors for that person to get compulsive with its use. And then they get to where they're abusing it, and then they are fully addicted. Fentanyl, has been a problem. Illegal fentanyl in our country. It's a prescribed pain medication, been here since 2013. But because of these problematic areas that we've had with the illegal distribution of it, and it can kill in very small dosages, we have a crisis on our hands with that. And that's where individuals need to be cautioned, particularly if they have a history of going to the street and buying drugs. So our rescue drug for opioids is naloxone. Don't confuse that with naltrexone. Naloxone, is Narcan. It's active for about 30 to 81 minutes. If you have to give this to somebody and they come to, they still need emergency room care, okay? So a withdrawal syndrome with opioids, this is when the drug is discontinued after a period of continuous use. They don't have to be detoxed, but they're going to feel like they were hit by a truck. Okay, it makes them feel terrible. They can be nauseated, vomiting, and they make it to the point where they need some assistance if they become dehydrated. Okay, but this is what I mean, that even though it's a central nervous system depressant, it acts differently than alcohol and benzos. A lot of these folks are still under medical supervision because, particularly if they've been a long-term abuser, okay, because of the effects. They can go through withdrawal, then they can have a week where they're finally over it, they think, and go through life for a couple of weeks, and then all of a sudden they get another week of those terrible withdrawal symptoms. So that's why a lot of these individuals are on this maintenance treatment with methadone. The buprenorphine, it doesn't produce the same intense high, and it decreases drug cravings. You'll see also buprenorphine and now naloxone combinations for some really high risk individuals. They, if you have an opioid addiction, you're typically going to see them on one of these maintenance treatments. But the goal is to gradually get them off these maintenance treatments as well. And this is a part of what we call substitution therapy in treating these individuals. And for pregnant women, because this is a real issue, you'll see them Subutex because it has just the buprenorphine only, and that's safe for pregnant women. And they have a history of opioid use. Inhalants. Most inhalants act like alcohol, except the nitrates, and they do it by depressing the central nervous system. These are typically abused by younger children more than adolescents. And then addiction is very rare, but the problem is it's typically fatal before addiction can occur. With inhalants, these are the different types. I'm not going to test you on the different types. Just know that there's 4 categories. With inhalant intoxication, you get that euphoria, sedation. They usually have emotional lability, impaired judgment. They do the sniffing because it's easily absorbed through the lungs and acts fast. But it can disrupt the normal heart rhythm too, some of these. And our long-term complication is widespread brain damage and cognitive abnormalities. When I say death occurs, there's this thing called sudden sniffing death, where they keep trying to sniff the substance over and over because that high is going away and they want to continue it, and they just overload themselves and death occurs. This is a good, to me, project to reach out to our children and adolescents, because this is what's available to them, these inhalants. And I follow the crowd, but many of them do not know the dangers associated with it. Sedative hypnotics, these are category listed, are kind of benzodiazepines. Again, if a patient is on one of these drugs and trying to come off of it. So life-threatening complications can occur, so they need to detox. You're not typically going to see withdrawal from these drugs. Sometimes, every once in a while, even our elderly population, that their doctor put them on benzodiazepine to help with their, quote, nerves, okay? The doctor doesn't typically stop it because they take it correctly. They're not abusing it. So if it's something that, you know, they've been taking correctly and it's not causing a problem or anything like that, you're not going to see their doctor trying to take them off of it permanently, because the withdrawal process can be quite challenging and they need to be in the hospital. But they need to be educated not to stop it abruptly, because they can start to experience unpleasant symptoms for which they need to seek medical treatment. And remember that initial slide I gave y'all of the different benzodiazepines broken down? You know, which one have they been abusing? It depends on their half-life and such as to when they will start having problems and experiencing symptoms. The barbiturates, you're not really going to see a problem with this because this is more, they're more hospital drugs. Okay, you don't see prescriptions written. But our Z drugs like Ambien, the Zolpidem, and the Lunesta, that's being utilized more and more. They're non-benzo type treatments for insomnia. Okay, but individuals can, you know, abuse these too much and rely on these too much, and typically have problems with trying to sleep if they don't use them. But they,
sorry, are the Z drugs like what Heath Ledger OD'd on, or?
no, that's your sleep substitutes, like I talked about, the Ambien.
Ambien.
Mm-hmm. And Lunesta and everything. Now, I mean, I don't know if that's what, I don't know off the top of my head what he OD'd on.
Yeah.
You can't take too many of these, and
I just know he was taking a lot of like sleeping aids because of the role he played in as the Joker.
right. Okay, steroids real quick. I'm talking about anabolic steroids. Those are used to treat, you know, delayed puberty in the medical world, low testosterone, underdeveloped testes, that type of thing. Some types of impotence. You may see them used with HIV if there's a lot of body wasting. But individuals will abuse anabolic steroids to promote skeletal muscle growth and the development of male sexual characteristics. There's a risk for heart attack, strokes, blood clots, cholesterol changes, hypertension, depressed mood, fatigue, restlessness. These individuals become much more irritable and very aggressive. You'll hear stories of somebody knowing somebody forever and they were mild-mannered, and all of a sudden they do this horrific crime or overreact with intense aggressiveness, and then they're found to have these steroids, anabolic steroids in their system. So that increased irritability and aggression is very problematic with these abusers, because the long-term use affects the neurotransmitter pathways that regulate mood and behavior. And that's why they become that way. I'm not going to hold you responsible. These are more FYI slides that I want you to look at, because I know some of you may have heard of crocodile. it got its name because when it's injected, it can leave a green scaly patch of skin. Just for you to know some of the things that are out there, okay? Again, there's non-substance related addictive disorders that your chapter doesn't really get into, except gambling, because it causes the same kind of brain changes as your chemical substances. However, when this lecture is given 5 years from now, there may be a complete change with this, with our ongoing research. So what is a nurse to do? Again, the goal is recovery. Realize that addiction is a lifelong struggle. If a patient goes through withdrawal or if it's detox, okay, because it was alcohol, after that's completed, that's when the really hard work begins. A lot of people think it's during the detox, okay, or the withdrawal process, but no, once they get past that point, that's when the real work begins, okay? So know that denial is a big defense mechanism that these folks use. Also, rationalization. You know, you would drink too if you were married to what I was married to. They will rationalize away their behavior. They've got to be motivated for change. Be careful of that countertransference. If you have a relative that has an addiction problem, okay, it can very well subconsciously come out with your behavior when you're treating your patients that have the same problem. So that countertransference we need to be on top of. That individual codependence is a number one problem, probably because of why they keep relapsing, because they keep going back to the same thing. They keep going back and hanging with the individuals that are drinking too, or smoking weed too, or whatever the substance is. Our priorities of care, deal with, first of all, if they're withdrawing, we got to get them through the withdrawal process. But then afterwards, we want that therapeutic relationship because they have to be the one to decide that they're going to get treatment. Yes, they can go for mom and dad, but unless they really admit, I have a problem, I need help, they're probably not going to change. Okay, so if in your inpatient settings, you see them try to set these individuals up for a 28-day program when they're discharged and they refuse to go, They can't send them. They can't make them go. All right, I'm going to stop here because Miss Barbara is going to get into the rest of this as she talks about the nurse recovery program here in a second. Any questions about this chapter or chapter 42? All right, I'm going to give y'all a break. If y'all can come back at 10:35 and we will finish up. How's that sound? Okay, I want to welcome Miss Barbara McGill. She works here at Northwestern with us. Come up here where they can see you. And she's taught an ASN program. She's helped us in the BSN program, but she has a psych background with the state board with this particular issue. So she's the most expert person I could get to come share with y'all at this time, okay? So I'm going to turn it over to her.
Okay. Let's see. How many in here have an addict or an alcoholic in your immediate or extended family? Yeah, it's usually less than 10% of us who don't have someone in our close lives who are an alcoholic or an addict. I had an aunt and an uncle, both of whom died of their alcoholism. So this is not, something that we spend a lot of time talking about. But how many do you have in this class, Dr. Alexander?
And there's 3 or 4 on Alexandria campus, and there's 16 or 17.
Okay, so about 20. So probably at least 2 of you will become addicted during your career, maybe more.